So this patient is difficult because most of the patient's not difficult, the decision making's a little difficult if you really go to the literature and try to find clinical trials that say, okay, for a patient who's had a type 2 aromatase inhibitor and has had a SERD or fulvestrant, what is your best option? I wish we had data that really could help us understand what the next step should be. Unfortunately, those trials are difficult to design and the endpoints are quite complicated, so we don't have a lot of trials that drive my decision. Again, I think it's a personal bias, which is that anti-estrogen strategy should be employed as long as possible before you make a decision to switch patients to chemotherapy. That's my bias. I think patients in general do well for a long time on anti-estrogen therapy. And the trial data would really suggest that adding a targeted agent to anti-estrogen therapy, at least in the first and second line setting, adds something. It adds toxicity, but it also adds efficacy. So I tend to believe that that would be the case past the first or second line setting, in this case in the third line hormone-sensitive metastatic setting.